Welcome to everyone tonight. It's a pleasure to have you on board for this webinar on the management of myocardial infarction. And I'm joined this evening with two experts in the field. You may well know them. We have Professor Pepe Zamorano from Madrid, and we have François Mack from Geneva. Both experts in cardiology and in the management of myocardial infarction. So we have received already a number of questions. We will get more along the way, and the goal is to keep some time at the end of the presentations to answer a maximum of questions. Without further delay, I think it's time to move on, and we will tackle both types of MI, ST elevation MI and non-ST elevation MI. Let's start with Professor Zamorano for ST elevation myocardial infarction.
Thank you, Gilles. I think it's a real exciting meeting. And as you said, it's great that we have a lot of questions already, but now it's time to ask all the attendees. So the question is, according to the ESC guidelines 2019, what is the best LDL lowering strategy in patients with high risk? So what do you think? Is a maximum tolerated dose of a statin? This is the best strategy. Is the simply ezetimibe? Is a combination of the maximum tolerated statin plus ezetimibe? Or if you feel that those patients with high risk, the above option, this means maximum tolerated dose of a statin plus ezetimibe plus adding a PCSK9 inhibitor. So please answer. Remember that we are dealing with high risk patients, not very high risk. So we will address that during the lecture later. But also remember that the target of the very high risk is different as the high risk. We will also address that. And the best strategy here, as I will share later some data, is maximum tolerated dose of a statin plus ezetimibe. We need to achieve the target as soon as possible. So let us move to the second question. Now we're going to deal with the very high risk. So again, the 2019 guidelines, what is the best treatment strategy in patients with a very high risk? Again, it's maximum dose of statin, ezetimibe, PCSK9 inhibitor, or all of the above. What do you think? So what we have changed here is the risk. So now it's very high risk. The target, therefore, is quite intense. We should move in the very high risk, as we will see later, less than 55 milligrams deciliter and 50% reduction. Again, there is a 1/4 of you think that with a maximum tolerated dose of statin will be enough. Well, let me share with you a real case now. And the real case is a patient that is 62-year-old, smoker, is a lawyer, maybe also at risk here. And this lawyer is telling us, I do not have time to exercise. I'm all day I'm working. He is not taking any alcohol, but he's receiving triple therapy for hypertension, valsartan, amlodipine, and thiazide. So he's admitted to the hospital, to our department of cardiology, with this ECG showing an acute anteroseptal myocardial infarction. Immediately was transferred to the cath lab. And as you can see here, there is a lot of information in this angiogram. We can see total occluded LAD, but also see the different lesions that we also have in the circumflex artery, and also some lesions also in the right coronary artery. So in fact, what we did immediately was primary PCI. We opened the LAD, we stent the LAD, and remember that this patient is not only with a plaque in the LAD, it's a patient with severe atherosclerosis in the three main vessels. So with admitted in the coronary care unit, and the patient in the lab test, it was normal, but except LDL was 190 milligrams deciliter. The Lp(a) was also elevated. The ejection fraction in the acute phase was 40%, and the patient was treated with aspirin, clopidogrel, atorvastatin 8010, and 5 milligrams bisoprolol. Well, I think this is quite relevant because if we remember some of the main trials related to the LDL lowering, you can see here that in the IMPROVE-IT trial, patients very high risk post-ACS in the first 10 days, is really relevant is that the standard medical therapy was done with primary PCI and so on. The patients were randomized to simvastatin 40 milligrams or ezetimibe simvastatin 1040. And what happened? As expected, the LDL was lower in the ezetimibe Simva arm, but of interest is that the Simva patients were nicely treated. So the LDL level was 69, that this was on target according to that date. So remember that in the previous guidelines, the LDL target was less than 70 milligrams deciliter. So in the other arm, remember that the LDL went down to 53, and you can see here that the trial was interrupted because there were clearly less events with a significant difference in the patients treated with ezetimibe Simva. So at this moment, going lower than the target proposed by the guidelines, that was less than 70 at that moment, going even lower was followed by a better outcome, better prognosis of a very high-risk patient. Who are patients at very high risk? Never forget that all patients with documented ASCVD all of them are immediately categorized at a very high. Also remember that patients with diabetes with target organ damage are also categorized as very high-risk patients. Also severe chronic kidney disease, but for this, you need to clearly establish that is severe, and a calculated score more than 10% implies very high risk. And what are the targets? The targets are different if we are dealing with a very high-risk patient or with a high-risk patient. The lawyer that we are treating now in our case is a very high with documented coronary artery disease with a documented infarction. And therefore, the target here is less than 55 milligrams per deciliter, and it is not or, as it was previously in the guidelines, is and a 50% reduction from baseline. So this means that we need to really go down with the LDL level of our patient. Remember, was admitted with an LDL of 190 milligrams. So it's below 55 and 50% reduction from baseline. The guidelines also do recognize that in high-risk patients, the target should be less than 70 milligrams deciliter and 50% reduction of baseline. So what is the algorithm? What is the strategy? So first, we need to establish the risk of the patient. And remember that it has been published that the estimated by IBOL, the estimated risk is much lower than the calculated risk. In our patient, immediately must be categorized as a very high risk because the patient has been admitted with an infarction. So we need to define the treatment goal, and this means that our patient the target is less than 55, as I said, and 55% and 50% reduction. Then the guidelines say start with high dose, high potency intensity statin. If the target is not reached after a few weeks, 4 to 6 weeks, we should add ezetimibe. And if the goal is not reached, then we add a PCSK9 inhibitor. The question here is, if this algorithm is already old, is old-fashioned, can we do it better? Do we have enough information to change that? Should we do it faster? So let me address all these issues. So remember, the first thing to remember is that we should know the target and we should achieve the target, because the guidelines are not the important thing. The important thing is the implementation of the guideline, and to know is not to do. So can we do it better? Can we treat better this patient? Well, first, remember that if you are dealing with a patient with an acute coronary syndrome, the probability of a second or a third cardiovascular event is quite high. So recurrence of events are frequent. So we need to treat not only the culprit lesion, it's not only stenting with a primary PCI that is crucial and save lives, but it also to treat all the patient, all the cardiovascular risk factors in order to avoid recurrence events. And therefore, in this slide, you can see that the target is different, as we said, if the patient is with high risk or very high risk. But if the patient, even high, is an extreme risk, this means that the patient suffers recurrent events in a short period of time, then the target should be even lower. This means that LDL target should be below 40. And why is this? Let us look back and see what had happened in science with the recent and the latest trials. If we recall the miracle at the beginning of this century, you can see that high-intensity statins versus placebo, you can see that with atorva, in the immediate acute phase after an acute coronary syndrome, you can see that the target level was 72 achieved with atorva and 135 milligrams with the placebo. But we can see here a clear difference. In the PROOF-IT with high versus low intensity statin 10 days after an acute coronary syndrome, here you have 40 milligrams of Prava and 80 milligrams high intensity, high dose of atorva. And there is a relative risk reduction of 16%. And the target, the LDL level, was 62 versus 95. Then we move in time to the IMPROVE-IT, as I already described. The nice thing of IMPROVE-IT is that both arms, the patients were on targets according to the guidelines that were published at that moment, so below 70. But going even lower in the arm of Simba plus ezetimibe achieved better results, so better outcomes, so good news for the patient. And recently, we have seen the data from the Odyssey trial, high-intensity statin versus alirocumab, that is in a clear, intense treatment, achieving an LDL level of 48 versus 96, with a risk reduction of 50% and a statistical significant difference between the patients treated with aliro and placebo. So we know that there is a clear causal factor between LDL, which is the big enemy for atherosclerosis, it's a great enemy, and increased high LDL levels implies vulnerable plaque. But the opposite way is also extremely important, because if we really go low with the LDL, it could be possible. One of the things that we were seeking for decades, which is regression of atheroma. And putting all the trials all together, so just analyzing this fantastic journey of what had happened with LDL and cholesterol trials, you can see that we have learned that getting very low levels of LDL implies much better outcomes for our patients. So then the next question is, well, is really a matter of time also is important? It's only a matter of the LDL level. It's clear that the incidence, as you can see here in this graph, the incidence rates by LDL cholesterol change are identical, regardless of if we use the low medium intensity statin therapy or the high intensity. And you can see that if you reduce, the more you reduce the LDL level, the better for our patient, regardless of the treatment that you're using. So in fact, in this graph, you can see what happened in the different colors when we have analyzed statin versus placebo or usual care, intense statin versus less intensive statin, ezetimibe plus statin versus placebo, or in the recent trials, adding PCSK9. And you can see, again, that is a clear benefit. When you go even lower, you get a much better result in the very high risk patients. And what is the best combination? I would say, what is worst? I think that the best combination is to start with high intensity statin, high dose, adding ezetimibe. And in those cases that we don't reach the target in the very high risk population, we should immediately add PCSK9 inhibitors. And in the latest guidelines, elegantly and efficiently led by Francois, there is a nice table that we can predict what is going to happen when we treat our very high risk patients. And we know that if we treat those patients with high intensity statin, we will achieve a mean, and this is important, a mean reduction of 50%. So there are some patients that we will not get the 50%. This is a mean. This means that in most of the patients, we will need, in the very high, we will need to add an added therapy, which in this case, the first step is plus ezetimibe. And with this, we reduce more or less a mean of 65%. And if we add PCSK9 inhibitor plus high intensity statin plus ezetimibe, then we can even achieve a reduction of 85%. So what we need, or what is really new, is a change in the paradigm after the latest studies with the PCSK9 inhibitors. Here we can see the results of the Fourier. Obviously, there is a much greater reduction in LDL in patients treated with evolocumab. What is quite interesting is what happens in months after randomization in terms of the events. And you can see here that this is not only that the lower is better, is that the earlier is better. And the longer time, you can see here the extension with the difference between both arms, the longer time on target is also the better, with a risk reduction that persists during the follow-up of our patients. So as a graph, or as an easy chart to recommend and to follow, is if we have a very high or extreme risk patient, like the lawyer that we are treating today, we define the goal, less than 55 and 50% reduction from baseline. Then we have class 1 in the guidelines, high potency statin at highest dose is recommended, and ezetimibe to reach the goal. Let us just reach the goal as soon as possible. And if it is not attained, if it's not reached the target, then we should add again as a class 1 a PCSK9 inhibitor. Do we have evidence, or should we treat in the same way if a patient had an old infarction or a recent infarction? And you can see here on the left part of the screen, if the patient had an infarction less than 2 years ago, that we see a real reduction of 24% in relative risk reduction with a significant difference with patients treated with EVO. This means with lower levels of LDL. You get a clear benefit. Also, there is a benefit in patients with a MI that lasts more than 2 years. But the benefit implies that the earlier you treat with intense therapy, the better for the patient. And in fact, when we analyze patients with a remote MI more than 1 year, you can see that the relative risk reduction is 8%. But what is really, really relevant is that you see that is after 1 year when you start seeing difference between the two curves. This is not the same if we have a recent MI. And you can see here that again, you have a relative risk reduction of 19%, but what is even more important and very interesting to see is that you obtain benefit earlier. So treat intense, treat early, treat in a prolonged fashion. So this means this is not a treatment only for the acute event or only for the first year. It's a chronic disease, it's a chronic treatment. Again, and we can go back to our patient. The patient had an anterior infarction with an LAD that is occluded. We opened that vessel. But remember that the patient had plaques even in the distal LAD, but also in the circumflex and in the right coronary artery. In patients with multi-vessel disease, in patients with more advanced disease, you get even more benefit. Obviously, we need to concentrate in those patients. They are very high risk. We need to treat intense. And once you treat in an intense way, see the graphs that diverge earlier and importantly. Finally, let us move to the last part of the presentation and the concept. We've been desiring, discussing, and waiting for regression of atheroma. And you can see here in the GLAGOV trial that indeed you can see a change in the percent of the atheroma volume when you reach very low levels of LDL. So regression is possible, has been described when you achieve very low levels. Intense, long-term, and fast. In this graph, you can see MACE, all-cause mortality, myocardial infarction, and you can see here with the different colors, the reduction in the LDL level. And the lines that you see here, they're quite parallel. Even you change, you obtain more benefit if the LDL is low, but with any level of reduction, you will see that there is a reduction of events early. Finally, well, after an acute coronary syndrome, as our patient, early and intense LDL reduction improved prognosis. This is obvious in terms of all-cause mortality, MACE, cardiovascular mortality, myocardial infarction, recurrent events, a lot of evidence. And quite interesting, and I like this graph because you can see that even hospitalization for heart failure has been observed a reduction in hospitalization for heart failure in patients with an intense reduction of LDL. This is a slide that I like very much. I took it from Gilles. It's early. Why? It's immediate control. It's clear, better adherence. Patient understand the problem. There is no downside. It's quite safe and is clearly beneficial for our patient. And is well tolerated. This is the result from the EVOPAC. The primary endpoint is the percentage change of LDL from baseline to 8 weeks with evolocumab in ACS patients. And you can see here that at week 4 and at week 8, there is a clear reduction, very intense reduction in terms of LDL level. Is it safe? For sure it's safe. You can see here in this slide what happens in patients with ultra low LDL cholesterol that was reached very early, 4 weeks after randomization. And you can see that there is no downside. It's a clear benefit in terms of reduction of events. To know is not to do. And we have data, the Da Vinci study. This is the graph of the very high risk patients. Most, they are not well treated. Many, they are not on targets. And the most important message is that don't think that those patients are the patients from other hospital, other doctor. It's your patient, it's my patient, and we need to take action here. So in conclusion, something to remember. All patients with an acute infarction, all patients with a STEMI are at very high risk, and they do have frequent recurrent events. We need to treat intensively, fast, and long-lasting. This long-lasting LDL reduction is followed by better prognosis and less event. Even lower, you have heard that many times, is even better, but we need to add even earlier and prolonged is even better. Thank you very much for your attention, and I'm sure you will enjoy now the lecture from Francois.
Very much, Pepe. That was a great presentation. And clearly, I think many of us know what we should do, but we also know that we often do not reach the goals that we have to reach. So we will discuss that later and take more questions from the chat and from the questions that were sent before. But Francois, it's your turn now. We are moving to NSTEMI and the management of these NSTEMIs.
Thank you, Gilles, and congratulations to Pepe for this first important presentation. He covers already a lot of very important information. I will ask now the techniques to give you, as for the first presentation, I think 2 questions that you will have 15 seconds to answer. What is the latest diagnosis strategy for the management of ACS in patients without ST segment elevation, so non-STEMI? You have 3 different possibilities here. So it's a bit, I'm happy that only 29% still using creatine kinase or creatine kinase MB. This is not recommended, as you will see in a minute in the first slides. You can use the algorithm for high sensitivity C-troponin either at 0, time 0, 1 hour. As you will see for non-STEMI, now it is recommended to do 0 hours and 2 hours. So thanks from the European Society of Cardiology, there is the 2020 ESC guidelines for the management of acute coronary syndromes in patients presenting without persistent ST segment elevation. So this is not the lawyer that Pepe presented to you. We are talking now here about non-STEMI patients or diagnosis. What is new from the previous guidelines on non-STEMI? As you'll see here on this slide, 2 differences on diagnosis and also on imaging and management that will come in the next slide. First, and this is answering the first question that have been asked to you, to the audience, as an alternative to ESC 0-1 hour algorithm, it is now recommended to use the ESC 0 hours, 2 hours algorithm with blood sampling at 0 and 2 hours. With the high sensitive C-troponin test. Now it is validated. Something else that is not mentioned there, please use some tests that have been validated in your hospital. Now, it is not recommended here in red for the diagnosis. It is not to routinely measure additional biomarkers such as the so-called old previous CK, creatine kinase MB, or copeptin, as mentioned here. Measuring BNP or anti-proBNP plasma should be considered and may gain in the prognosis of some patients when available. You may be familiar with this table showing STEMI and non-STEMI patient with on the left side the so-called rule out with normal ECG, no ST elevation or depression, and at least 2 measurements of troponin negative, high sensitive troponin negative at 0 and 2 hours. Then it is a rule out acute MI for sure, non-cardiac symptoms. Then you have in the middle patients with either ST, non-ST elevation and ST depression that may have normal or not measurable troponin at time 0, and the delta is important. And if the delta raised for this patient with non-ST elevation or ST depression, the so-called non-STEMI, these are the patients that need to be managed for acute coronary syndrome. Keep in mind that this patient with non-STEMI have the same very high risk as Pepe mentioned at a year. Maybe not at the time of the presentation in the emergency room or during their transfer within 24 hours to do a CAT angio procedure, but within weeks and months, these patients have exactly the same risk, mostly because they have multiple vessel disease. Now, regarding some new, this is a busy slide, I'm sorry, and I'm pretty sure some of you know already. There are some new things about antithrombotic treatment and invasive treatment. Mostly for the antithrombotic treatment, you will see a table about patient coming with an ACS, non-STEMI, and having atrial fibrillation, what to do in these patients. This is an important table, patient with FAs at the time of NC elevation, non-ST elevation acute coronary syndromes, and they will go for PCI, what to treat for antiplatelets drug. As you can see here, default strategy will be, as always, triple therapy for a week, meaning a NOAC and a dual antiplatelet therapy, aspirin plus one of the P2Y12 receptor inhibitor. And depending on the patient high bleeding risk or high ischemic risk, you have this algorithm to follow. And it's a bit complicated, but you have to follow your patient and have them at a visit after a month if the patient is at very high ischemic risk, because he or she will be on triple therapy, meaning a NOAC and an aspirin and a clopidogrel, a prasugrel, or a ticagrelor. Then, for the next remaining 10 or 11 months, dual therapy with a single antiplatelets that could be aspirin or clopidogrel. And you have the different strategy depending on the patient risk of bleeding, obviously with less first time with triple therapy. What about the management for doing a rapidly coronary angiogram, and most of the time a PCI, or sending the patient to the surgeon, which could be also very important to have this done quickly. As you'll see on the left, ST segment depression plus 1 millimeter of 6 leads plus stegma elevation, ST segment elevation, will be an immediate need within 2 hours for angiography, as for the patient that have been presented by Pepe, the ST elevation clear acute STEMI. That would be a very high risk patient, even though this is called non-STEMI, within 2 hours, if there is ST depression and ST segment elevation together. Now, patient with classical ST diagnosis on ECG should have their angiography within 24 hours. And this means also resuscitated cardiac arrest patient without ST segment elevation or cardiogenic shock. Now, something which is new in these 2020 guidelines for the management on non-ST segment elevation patient, as you can see here, within 24 hours of management for the patient with transient ST segment elevation before these patients were more aggressively treated within 2 hours. What about cholesterol lowering? Pepe has covered this a lot. There is not a lot of difference between STEMI and non-STEMI patients. Actually, I don't think there are some differences. We should all be aware that LDL is now causal. It has been demonstrated by many different ways that you can see here on the left. It's not a hypothesis, it's clearly a causal, high LDL cholesterol, high risk of events, low cholesterol. If we can lower, even in very high risk patients, we will just reduce their risk of future events. You have seen this table nicely described by Pepe recently for high and very high risk patients, the new target below 70, below 55. There will be, if I may add an argument, a comment there, there will be more and more patients that need to be treated in the high and very high risk category. The classification to go there will be much more patients. All diabetic patients are here now by definition high, very high risk. And all persons or patients with familial dyslipidemia will be high or very high risk. And for familial, it might be difficult to reach. 50% might be easy to do, but below 55 might be sometime difference. We also added, and this is not a real guidelines, as you can see here, might be considered. Some countries in Poland and in Canada, they went also there as a new classification, either very, very high risk or extreme risk patients for those who experience multiple vascular events within a couple of months, 2 years, while taking statin. And we will see more and more of these patients on statin, as Pepe mentioned, not at goal, having a new event. Then I think it's fair to try to place them as low as possible because it's safe, as you have seen, and you will see new data in a few minutes, to place them at an LDL goal below 1 millimole per liter or 40 milligram per deciliter. These guidelines have been quite well endorsed and well seen. I'm pleased to mention this. I went to the metrics quite a couple of days ago. Total views on the net is more than 1 million, more than 3,300 PDF downloads. And this paper have already been cited in other papers more than 3,600 times. So question, how many percent with high intensity statin and ezetimibe decrease LDL by? High intensity during the pool, during the time, it's either atorvastatin 40/80 or rosuvastatin 20/40 plus ezetimibe. Is it 50 as a mean from baseline? Baseline meaning without treatment, 65 or 85. So the answer is right for 62% of the participants. It's as a mean. If you give atorva 40/80 plus ezetimibe or combination of rosuva 20/40 plus 10 milligram ezetimibe, as a mean is 65% from baseline. So it means, as Pepe mentioned, that the first goal, 50%, has been achieved, will be achieved by most of the high intensity statin actually, but to be below 70 milligram or 1.8 or below 55, even much more difficult. Most of the patients will need combination, as you will see in a minute. So I will move now from this. This is the result that you can see here, 50% for high intensity, 65, and when you add to this high intensity statins, ezetimibe, and close to 85%. So beside the very, very high, rare, fortunately, familial dyslipidemia with LDL above 7, 8, 9, or 10 millimole, most of the patients, if they could benefit and tolerate high-intensity statin, ezetimibe, and one of the alirocumab or evolocumab PCSK9 monoclonal, then with 85%, 90% of these treatment, most of these patients will be on the new targets. I will go quickly on this because it has been nicely summarized. Statin first. We can discuss why we need to wait. These are guidelines where we need to have evidence from randomized controlled trials. And this is why we have this step-towards approach. First statins, if not at the goals quickly. Quickly, we can discuss what we mean quickly, add ezetimibe. And if not, this is the case for familial hypercholesterolemia as well. What about ACS? There is a big debate, and probably in the next guidelines, there should be something else here at class and level of recommendation. If patients coming with an ACS at LDL level, not at goal, despite taking statin, we should immediately treat them with a PCSK9 monoclonal inhibitor. And we can also discuss, and hopefully there will be question there on the first rectangle there, why we should wait 4 to 6 weeks if the patient is not at goal to add ezetimibe, and then another 4 to 6 weeks. This is based, I can answer the questions already. This is based on the randomized control trial and the evidence from trials. But my guess is that this could be replaced by a class 1C. There will be no trial that will compare placebo to PCSK9 at the time of an ACS. So I guess there will be a class 1 and a panel expert C in the next guidelines, but we can discuss this in a few minutes. Pepe has nicely presented the EVOPAC study that has been done in Switzerland by colleagues and myself. As a summary, if you can place your patient at the time of the ACS, STEMI, non-STEMI, with a good statin, here it was 40 milligram atorvastatin, plus an anti-PCSK9 in this study, evolocumab, at the time of all patients were injected within 24, 48 hours. STEMI, all were injected within 24 hours. Non-STEMI, due to the delay of the angio, within 48 hours. At week 8, 2 months after the ACS, 90% of the patient will be at the new targets, which mean below 50% and below 55 milligram deciliter, compared to only 11% if you just give these patients a quite high potent statin. Now, this has been completely reproduced a couple of weeks after. We didn't know actually at this time. Maybe the company who generated evolocumab knows, but it was completely confirmed and reproduced in the United States. With one more item, which is quite important here on the left part, they were able to measure daily LDL cholesterol. And you see here that it is not only safe, feasible and safe, and very efficacious. Here you can see after 1 day, after 3 days, at day 4 or 5, you are at the limit below 40 milligram deciliter. So very rapid, very safe, very feasible, honestly, reducing of LDL cholesterol. Pepe has shown this to you. The more recent DMI, the more high risk of having a future event. Not surprisingly, it's a sub-analysis that we have done together with Baris Ganser in the Fourier trial. The recent MI, the more aggressive, the more unstable plaque, if we can say, you will see why I'm mentioning, will be the most to benefit from an early and safe treatment on top of statin with evolocumab, as you can see here, nicely demonstrated. And in this study, the risk of cardiovascular death, MI or stroke was reduced by 25%, NNT 32 over the 3 years for recent MI, meaning within a couple of months. Now, I'm very happy to present this data on Fourier-Ole, which is the extension, open label extension of the Fourier. And it's a very important study regarding safety. What they have done, they could not have took all patients in the Fourier. It would not have been ethical to keep half 13,000 on placebo with a high cholesterol LDL and a high risk. So you could argue that why they don't took all the patients, 27,000 patients followed by another 5 years, cost. So they decided to do something very clever. They took completely random 3,300 patients in the placebo group from the Fourier trial and another 3,300 patients from the evolocumab group. Exactly the same risk of patients, women, men, young, diabetes, smokers, exactly the same. These 6,600 patients were placed on an open label. This is very important. On an open label on evolocumab for another 5 years. So you have patients here that have 8 years of exposure to evolocumab. First message on this graph, there is no tachyphylaxis. If you start your treatment today with evolocumab, you can tell your patient that cholesterol will be lowered by 50-55% lifelong. And this is very important. There is no risk of the drug to be less potent in this kind of body. And most importantly as well, what about side effect? To live with a cholesterol LDL below 1 millimole, exactly 0.8 millimole for 1, 2, 3, 5, 6, 7, 8 years of follow-up. Completed graph, but as you can see here, absolutely no more serious adverse event on time exposure. Remember, 7 to 8 years. No injection site reaction, no increase of reaction, no increase of reaction drug-related allergic, no increase of muscle-related event. So the lower you have there is no more risk to induce some of these side effects. And the new onset of diabetes seems it is not statistically significant. I don't think we understand now why. It seems that at least the risk of new onset, which is increased with statins, it's clearly not there by lowering LDL very low, very rapidly, very safe with this agent, evolocumab. And there was some rumor that with very low LDL, we may induce hemorrhagic stroke. Look at the numbers. Absolute numbers is below 1%. And it is not increasing with time exposure to this drug, evolocumab, with very low LDL. You just reduce the risk massively on these high-risk patients. This is the result, difficult to understand. This is the result from the 5 years on an open label. Cardiovascular death or MI or stroke is reduced in the patient that had been exposed before with a very low LDL. Here, all have the same drug and all have the same level. Even more impressive for cardiovascular death. It means one of the explanations is that there is a lag and there is a legacy. And as Pepe mentioned, why wait? If the patient today say, oh, I'm going to start in 2 years, you can tell him or her that he or she will have a high risk in years to come to have a soft plaque that will be destabilized or unstable and will induce, even if I can place your LDL low in a couple of years. Why wait? That's an important message of this 4-year OLE trial about safety, about efficacy, lifelong, and the fact that we should start as soon as possible. I cannot give you more than this slide. We went with other colleagues in much more granularity to look at safety outcome. I just present to you a few items. We look at cancer, we look at cataract, we look at kidney function. Absolutely no fears. With this drug, evolocumab, to lower LDL very low. Remember, the mean is 0.8 millimole per liter, close to 35 milligram deciliter, for more than 7.5 years as a mean for all these patients. Absolutely no fears of any kind of side effect. Now, how it works, I will finish on that. This is an elegant study. Pepe has presented to you the GLACOV study. This is the next step, is to look at not only the plaque quantity, but the plaque quality. All these patients in the Huygens trial had an ST elevation MI. They all benefit from statin, and they were all accepted to be either on placebo or evolocumab, double blind, for 1 year, only 1 year of treatment, reducing massively, safely LDL cholesterol. And then you look at atherosclerotic coronary plaque volume, but also the quality of the plaque. And maybe Gilles could comment on this much better than me, but as you can see here, only good result. An increase in the minimal of the fibrous cut thickness. These plaques are more stable. The remaining plaques are more stable. They have less lipid content in the vascular wall, not only on the blood flow, but on the vascular wall. And they were able to confirm that it was less plaque volume. So this may somehow help us to understand why we should lower LDL as soon as possible to stabilize the plaque, to reduce their volume, and this helps to understand why these patients will have less events. But I'm quite proud to present this, Gilles. This is a study designed by Gilles Montalesco and some colleague in Paris. And we are part of this study, Amundsen, the Norwegian guy who discovered the South Pole. And this is Mother Nature, as we do in daily practice. 1,600 patients will be placed on a, it's a randomized trial, and Gilles can comment, not placebo control. If the patient say yes, he may be offered evolocumab from hour one. We have to inject in the cath lab. And the other patient will be optimal medical therapy, including, if they want in the future, if they are not at goal, including PCSK9, but Gilles could comment on this. This will be hopefully finished, the inclusion by the end of this year or next year. So as Pepe mentioned, yes, for an earlier and lower LDL reduction after all ACS, could be STEMI or non-STEMI. We need to screen for FH as soon as possible, measure including Lp(a). We don't have time today to discuss this. We don't have fears, and the Fourier-Ollé trial is a very important demonstration. We don't have fears to reduce LDL in the blood, very safe for a long time. Now we have the very high-risk new category of goals and target, 50% and below 1.4, 55, difficult to obtain without combination. We have learned a lot from the diabetic and the hypertensive field. They combine, and we should use more and more as soon as we can discuss the statin ezetimibe, and for a lot of patients that will need PCSK9 monoclonal inhibitors. Together with Koshre and other colleagues, we have placed this in a so-called consensus. And this is the summary. We should move away from high-intensity statin treatment and the wait and watch paradigm, and instead start treating all very high and extremely high-risk patients with combination therapy as the basic standard of care. And this will end my talk by the sooner, the lower, the better. And this will, with full adherence, will reduce the risk of future cardiovascular events in these patients, which are residual risk factors for developing ASCVD beside LDL-C. So assuming that you are doing very well, your patient is doing very well with LDL-C, he or she is on target. So I think you are quite okay with the fact that there are still residual risk factors beside LDL cholesterol, thrombotic risk, as we will see in a minute, inflammatory risk, as you will see in a minute, which are residual risk factors for developing ASCVD beside LDL-C. So assuming that you are doing very well, your patient is doing very well with LDL-C, he or she is on target. So I think you are quite okay with the fact that there are still residual risk factors beside LDL cholesterol, thrombotic risk, as we will see in a minute, inflammatory risk, as you will see in a minute. Inflammatory, yes, has been proven by some elegant study, CANTOS, very expensive and some side effects, but clearly without touching LDL, reducing inflammation improve the risk of future cardiovascular. Thrombotic risk also has been shown by COMPASS and Pegasus and others. Triglyceride, reduce it, prominent, we can discuss fibrates. Lp(a) is something very, very important. And also SGLT2 inhibitors have been proved to reduce not only the risk of hospitalization, but also cardiovascular death in very high-risk patients. With this, I would like to thank you, and we'll be pleased to be part of the discussion. Thank you.
Thank you very much, François. That was beautifully done, and it's time for questions and discussions. When I look at your last slide, it's impressive to see all these residual risk that we may see in our patients. It's interesting to see that for inflammation, for example, we can measure inflammation with CRP, for example, but we have no drugs For the thrombotic risk, we have drugs, but we have no markers. And this is the contrast that we see in the evaluation of patients. Sometimes we have drugs, but we don't know what is the level of risk. And in other situations, we have the good marker for the level of risk and no drugs. Sometimes we have both, and this is the case for LDL cholesterol. So I have a number of questions, and clearly we may start with the chat. Maybe both of you said we need to get this LDL cholesterol very low, and we need to do that fast. But how fast shall we do that? Is there really a risk of waiting for these patients, taking our time just to get the patient back to the consultation with a new LDL cholesterol, adding the drugs one after the other? How soon shall we get to the target? Pepe, what is your answer to this question?
Yeah, thank you, Gilles. This is quite relevant. I mean, it's not only that the sooner the better, it's also that maybe that the later is too late, because sometimes if we delay the treatment, the patient is not coming, or if we say, as the guidelines state, let us wait 6 weeks and then reevaluate the patient. Well, sometimes the patient is not coming. So we need to do it during the admission. And this is really, really my advice. So the patient should be discharged at least with a combination of ezetimibe plus high-dose statin. And if you presume that you are not going to achieve the target, and we can calculate, we can estimate that, then we can add directly PCSK9.
Francois, I know some of us do that already, combining right away high-dose statin with ezetimibe. You were the chair of these guidelines. This is not what we have in the guidelines. They are 4 years old now. Are they too old? They say to wait for ezetimibe. Shall we wait really?
So thank you for this question. I was not alone. I had two friends, Merico Catapano and Colin Benjen, to help, and multiple other colleagues in the task force. They all voted for this. We were based on randomized controlled trials. Both of you were on guidelines, are on guidelines. That's what the fact. I mean, even IMPROVE-IT added ezetimibe after somehow running period. Odyssey outcome, you know better than me. Alirocumab was added after 2.5 months. But basically, this is what we are doing in daily practice. Depending on the level of LDL at baseline, we add immediately. Most of our patients have a combination now. They quit hospital after 4 or 5 days, STEMI on combination, statin, ezetimibe. For some of them, very high, we try to, but that's a matter of reimbursement. After, how can you reimburse Repatha or Praluent at the time of an ACS? It will be difficult, but if I have no problem with payers, we know it's safe. And I think all the patients should be on a combination, all with statin and ezetimibe. And for lots of them, you can add whatever Aliro evolocumab. One has been tested, and that's it. But I'm pretty sure there will be a need in the next guidelines, or at least something which will be a consensus to say that it will be class 1 level C. There will be no randomized control trial. Neither Aliro evolocumab inclisiran will do it. It costs too much, and they know we are going to do it, or we are doing it. And I know in some countries in the Middle East, it is already done. If you go to Saudi Arabia, they place their patients immediately during ACS stay in hospital with evolocumab or alirocumab to soon safe reduce LDL cholesterol. And hopefully this will be done in a couple of months in guidelines, yes.
So Francois, what you're saying is that there is no point where low can be too low, because it's not yet accepted. I get phone calls, and probably you also, from GPs saying, you're completely crazy at the hospital. I have now a patient with negative values for the LDL cholesterol. So we have to explain again that these negative values are not negative really, but do you want to discuss that?
Exactly. I think that there is no negative and there is should not be any fear. I mean, we have that evidence published in Lancet by Bob Giuliano in 2017, and very ultra low levels of LDL. They were safe and also added value in risk reduction, so lower events. So I think that moving or going away from the economic financial issues, there is no reason why we should go fast and extremely low with LDL.
So this is also what we do, Francois, in Amundsen. You are part of this study. We run the study in your country, in Spain also, in Italy, soon in Poland and Germany, and of course in France. We have these STEMI patients on the table at the time of primary PCI. We randomize them and we inject them with evolocumab on the table even before the first balloon is inflated. Is it the right thing to do? Is it too aggressive? François, what do you think?
No, it's definitely not too aggressive. Again, the only issue is to have a guidelines class 1 level A. You will need more trials. We will never have them. I like what Pepe mentioned. We have now 8 years, very safe. I mean, this is 35 milligram deciliter for 8 years, or 0.8 millimole, 8 years. We have studies done by Aliro and evolocumab. Both have shown that you stabilize the plaque rapidly. You stabilize the plaque very safely. Hopefully, there will be more and more users. It's going to depend on the payers. Again, in many of our countries, I'm not sure that because of the price of this drug, to be honest, that we're going to be able to use them for everybody. But the evidence, not randomized control, but the evidence from plaque stability, from very safe, and from Fourier retrospective postdoc tell us that we should go as soon as within hours, as we are doing in Amundsen. Yes.
And Francois, what we see from Oli Fourier and from other studies now is that it's not a question to get the patient with a low LDL rapidly. It's also the time of exposure to these low levels that are going to be very important for prevention. You need it for years and years to see a benefit on clinical outcomes. But is that right?
Yes, this is one of the explanation of the Fourier-Oli outcome trials, that even though all the patients were for 5 years in the same LDL, very, very low, very safe, some of them, the one who were before the 2 first years by random in the active group, still have less event. What should be the case if you continue to follow these patients another 8 years, then these 2 blue and red should merge again. Because I think at the time when you have a very low LDL cholesterol, with time, the fact that you were for 1 or 2 years high, after time should decrease, and they all should be protected. But Fourier only tell us that there is absolutely no reason to wait.
Yeah. If I may also, Gilles, I fully agree what Francois said, but it's not only that the exposure of lower LDL levels are safe, it's also that exposure, long-term exposure to high LDL levels is quite toxic.
Mm-hmm.
So we need to avoid that.
Mm-hmm.
So I have a couple of other questions. Pepe, how often LDL levels should be measured? What do you ask to your patients?
Yeah, this is a very important question, and the answer is that there is no fixed time, because it depends from patient to patient and also the response to treatment. So what we do in our hospital is, if you have a very high risk patient after an acute coronary event and we treat intense, fast, very early, then we recheck what happens after 3 months. And it's not after 4 weeks, because we don't do the second step, adding ezetimibe is included in the discharge. Then between the second and third month, we do check. And if the patient is already on targets, Then we have a clinical visit with clinical status and blood analysis 6 months. And if everything is going properly, then the GP is following the patient and is coming to our hospital yearly.
François, I have another question here. What other factors can affect the LDL levels? What about diet? What about changes in your status, diet, for example, exercise, and so on? Is that effective?
Yes, I mean, all our recommendations should start with what we call healthy lifestyle. It's very easy to say, and it's not easy to implement. I mean, stopping smoking is not easy, and bravo to all of them. Then you may gain weight. We are asking to sometimes lose weight. We're asking to do gymnastic or to do physical activity and to eat a bit more, whatever you call it, Mediterranean. It works. Of course, it works. But as me, patients go back to smoking sometimes. They go back to gaining weight, and they do some exercise when they can. So it's very difficult. And honestly, we have the proof, and it is more easy to prescribe a drug. I'm not saying to take a drug. And we can thank the two companies that provide us with injectables that have been proven to be effective on outcomes and safe. Again, a bit expensive, but the patient has to inject him or herself, and the cholesterol, it had to do also what I just mentioned, stop smoking if still there, and do physical activity and try to eat a bit more Mediterranean. Easy to say. Again, for doctors, it's so elegant. I will reduce your cholesterol by 50% at least, 50, 55 by one injection each 2 weeks. Safe. Then, of course, you can be even lower by eating more banana, cereal, blah, 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 stop smoking and doing gym, of course.
Pepe, one more question here. We know that compliance to treatment is not very good with statins for various reasons. That may be side effects, that may be tiring effects of taking drugs when you're still young and active. How can we improve compliance to treatment for these drugs? And do you think it's going to be easier with evolocumab because it's injectable, it's every 2 weeks, or do you think it's going to be the same as with statins? We will lose patients because they stop treatment anyway.
Yeah, I think this is an extremely important issue. I mean, no doubt that the important thing in medicine is implementation of the knowledge. So the bad press that we need to recognize that is there related to the statins for sure influence in the bad adherence. How can we solve that? No doubt education is crucial. In terms of evolocumab, if this is the new way of administering the drug will help, I think that now it may help. At the beginning, it was a new thing, a new way to treat our cardiology patients. I mean, this was not normal. Now it's absolutely normal. The patients, they feel comfortable, and they like the thing of the seeing that the LDL is now according to their targets. And I think that this may help really the adherence to the therapy.
Another question for you, Pepe. Should every patient be on a beta blocker after myocardial infarction? What do you think?
Well, the answer is no. Beta blockers really save lives, no doubt, but mainly in patients with depressed ejection fraction. I mean, if you are dealing with a patient with an inferior myocardial infarction, the LV function, the systolic function is absolutely normal. There is no solid evidence about that. But all our patients with depressed ejection fraction or heart failure or a huge myocardial infarction, we treat with beta blockers as soon as possible also.
And what is the most useful antiplatelet agent after myocardial infarction? This is another question. Probably not for the acute phase, we know them, but on the long run, which is the last antiplatelet agent you're going to keep on this prescription?
Well, in fact, after acute stenting, we tend to keep the patient with DAPT, with dual antiplatelet therapy. Usually is aspirin with Cloppi or with Brilinta. And for the long run, in Spain, we used if the patient is not in atrial fibrillation, obviously, but is sinus rhythm, we keep the patient with aspirin.
Aspirin. So some of us would keep clopidogrel, some others would keep ticagrelor.
Yeah, Tica is not for the long term in Spain. We use that mainly as DAPT for the first year after stenting. But Cloppi, if the patient has some neurological symptoms, or if the patient has atherosclerosis in the carotids, and then the neurologists, they tend to use more Cloppi than aspirin. But cardiologists in Spain, we use to mainly treat in the long run with aspirin.
Francois, what do you do?
Fully agree. Some neurologists, they send the patients back to Cloppi, which could make sense if they have transient attack and acute coronary syndromes. On a long way, I will take more prasugrel, but I don't think we have data with ticagrelor or with prasugrel on the long term based on the cost benefit compared to aspirin alone.
Also, I would like to pick your brain on lipid management again, because it's important to get LDL down, but we didn't talk a lot about the other drugs available, like fibrates. Any room left for these drugs, or are they dead forever? What about icosapentadine, which is coming up on the markets everywhere? Is it a good drug? Shall we look at triglycerides and use this drug when we have a patient with more than 150 milligrams per deciliter? What about bempedoic acid, another option? So we have other drugs around. Are they useful?
So first, for starting by the end, bempedoic acid, the answer is quite easy. There will be in a month from now the release of the CLEAR Outcome trial at the ACC, I think on a Sunday, that we will see. It's a very important and very difficult, and they were very courageous. I think the commentator will thank the trialist. It's 13, I think at the end, 14,000 patients, very high risk, intolerant to statin. You, me, Pepe, we treat patients daily with, they are complicated patients, these patients. They would, I hope they don't have too much dropout, but we will see. Bempedoic acid alone, I'm not a fan, 20% ezetimibe. Safe, no muscle pain, yes. And then together, they have a combination already on the market with bempedoic acid and ezetimibe. This is more close to 30-35%. So in primary prevention, there will be no bad press, as Pepe mentioned. It's not a statin, even though it's on the same pathway. No muscle pain, but we will see by a month from now, 5 weeks. Now, the other issue is triglyceride. I think triglycerides are not dead at all. Fibrates are dead after prominent trial. But the fibrates, they lower LDL by 20-25%. We will see there are now trials with antisense or silencing or small interfering RNA that will lower LDL by 60, 70, 80%. If these drugs are safe, injectables, then we will see what is the gain to lower triglyceride massively. The last point is about EPA. Yes, EPA is coming on the market. Even though you may argue about the reduced trial, you take 1 or 2 0 out of this fantastic p-value. No doubt that, yes, there is an effect on adding in patients with high risk and high triglyceride to add EPA. I'm pretty sure there will be not a small niche on the market with 2 grams twice a day.
Okay, that's very clear. I think, gentlemen, we are reaching the end of this session.
Thank you very much.
Bye.